Diabetic retinopathy is the leading cause of acquired blindness in adults in the United States. And one of the things that's so interesting about it is that there are life-saving and sight-saving interventions that can be applied early if we identify it. Nationally, only 50% of the patients that have diabetes in this country actually get the required screen, which is recommended to be once a year for all patients that have diabetes, and in some cases every 2 to 3 years if they're well controlled. However, patients that are in racial and ethnic minority groups or from lower socioeconomic groups tend to have rates that are much lower than the national average. At Community Health Center, Inc., we found over time in the years of 2008 and 2009 that only about 10 to 12% of our patients with diabetes were actually getting the annual recommended diabetic retinopathy screening.
I know I have diabetes in my family, so I eventually knew I was going to end up with diabetes, I guess because it's hereditary. I did not know that I could lose my eyesight because of diabetes, but when I found out, I was definitely glad to know, and I booked an appointment right away.
We decided to look far and wide to try to find what would be a good solution to taking care of this low screening rate phenomenon in our population. We found a very good example out at the University of California, Berkeley, with the EyePACS program. Using telemedicine, they would implement this kind of screening in the primary care office, have the images captured by a digital retinal camera in the primary care practice office, and then upload these images to a secure server where ophthalmologists and optometrists could go in and do a detailed reading of that image and provide that information back to primary care providers. In 2009, we purchased our first digital retinal camera and formed a collaboration with the Yale Eye Center and their retinal specialists, as well as the University of California, Berkeley EyePACS program.
The way diabetes damages all of our body, and including the eyes, is by damaging the blood vessels of our body. Here we have a patient with diabetic retinopathy. You have areas of this redness that's actually outside of the blood vessel. These are areas of the hemorrhage, and this patient has numerous areas of the hemorrhage that's associated with the diabetic retinopathy, damage to the blood vessels in those areas. All these changes can cause vision loss in these patients. This would be the individual patient with their basic demographic information, their diabetes information, such as their hemoglobin A1C, what their blood pressure is, what their cholesterol level is, when the last time they had an eye exam, how many years they have diabetes, and their level of visual acuity. All these important kind of information help us to determine basically really how often we need to follow the patient, how aggressively we need to treat the patient, and information I need to communicate with the primary care. Here on the bottom part of the screen, you can see that these are basically the thumbnail images of the EyePACS images, and once I click on them, basically the images actually pull up, and these are the images I review. And there is an area where we can actually essentially generate a whole console for the images that we reviewed.
The program coordinator goes in and makes sure all that information gets put into the patient's electronic medical records, and from there our providers can decide what to do with the patient. Do they need to be seen in person? Are they okay? Do they need to come back in 6 months to be screened again? But it gives them the basis to manage the condition.
We don't necessarily have some of the challenges of the patients that are in rural California. However, we did really have an access problem for our patients. In some cases, it was due to the fact that they didn't have insurance. So 25% of our patients at the time did not have insurance at all. In some cases, it was due to the fact that our patients might have had insurance, public insurances, but they were not accepted by many of the specialists. In other cases, it was due to transportation. In some parts of the state, our patients have a very difficult time getting to a place where they can get this care. Some places it was due to cost, and in some cases it was due to language barriers.
It's really at the patient's convenience for when they come in, and we're able to get them results within 72 hours. With those results, once we get them, if it does show that we've got diabetic retinopathy in our patient, we're able to explain to them the reason why we need them to go to the ophthalmologist instead of just saying go for a routine screening, which they're less often able to go to.
Our screening rates doubled in the first year of the program. So we went from having a very small percentage of our patients being screened in our diabetic population of, at the time, under 4,000 patients to nearly double those rates with 2 cameras that were rotating around the state. We decided that we didn't just want to build a program where our patients would come and get a quick image of their eye, but what we would do was combine that with diabetes education, a good diabetes nursing visit, and give them the opportunity to have an annual comprehensive diabetes visit. So the role of nursing became critical in being able to deliver on not only the retinal screen, but also a comprehensive plan to manage their diabetes.
What happens is we'll start off by asking the patient, is there anything that they want more education on? What would they like to learn about diabetes? So we've got a little handout, we call it the stoplight handout. So green means you're well controlled, yellow means we need to make some changes to make sure you don't get into our dangerous red zone, and red zone means stop where you are right now, we need to reassess and make some changes so we can get you out of the risk area for all sorts of complications, including diabetic retinopathy. And we'll talk to them about some self-management goals. Right now, how often are you walking?
Having a diabetes education with a nurse helped me very much because they were able to show me how to do what I needed to do to keep my levels under control.
We were able to find, by looking at close to 700 patients' data in that first year, that only 13% of our patients actually required a visit to the ophthalmologist. That was amazing from a cost perspective. The ophthalmologists were very excited about that piece of information because they said, well, if you can reduce the demand on our system, we can get the patients that really need to be seen in. We were also able to find that by coupling the digital retinal screen with a nursing visit, close to 70% of our patients were able to get self-management goals set with the nurse. They were able to get diabetic foot exams that they were due for or get vaccinations that they needed and have a really good diabetic teaching visit with our nursing staff. And then finally, one thing that's hugely important for payers and for the system at large is, does this save any money? And we found that to do this telemedicine-based screening for diabetic retinopathy versus the conventional ophthalmology visit for diabetic retinopathy, we could save $25 per patient for every time that they had this visit, and that's huge.
All of the costs of the program are upfront, investment in the camera, investment in training of staff, and from there on, there's really minimal investment that goes into the program. And it's very easy to scale up to other sites. When we started, we had 2 cameras and we screened at 7 of our medical sites. Now we have 5 cameras and are screening out of 11 of our 12 sites with minimal extra investment in the program.
In the last 10 years, there have been major advances in the care of diabetic patients and basically patients with diabetic retinopathy. All these therapies basically are able to really kind of treat patients, stabilize their vision, and in some small selected group of patients actually improve their vision. By catching the disease early, we can actually get these patients early in the disease course and prevent them from losing any vision, preventing developing visual disabilities secondary to diabetic retinopathy.
My diabetes today is on the mends because of diet and I want to say medication. Before it was so out of control. It was like all the way in 200s, 300s all the time. And then now that I've started doing a lot more dieting and exercise, it's better control. It's still out there, but it's not as bad. I would recommend the program, absolutely, because the number one thing is for you to know what's going on, prevent it if you can, and get treatment.
You're welcome.